Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to the Gastro Girl podcast. We are so excited for this episode. I can't believe it's a year, Dr. Levy, since we've had you on the show again. We're going to talk about Colorectal Cancer Awareness Month and about the fabulous Tune It Up concert to raise awareness of colorectal cancer, which returns this year on Thursday, March 28th. So excited. Welcome, Dr. Benjamin Levy. So glad to have you here.
Thanks for having me again and allowing us to talk about screening and the concert.
Yes, but I want to remind everyone that you are a practicing gastroenterologist at the University of Chicago, and you're also on the ACG, the American College of Gastroenterology's Public Relations Committee, which is so cool. And I'm so happy that you're doing this concert again. This is what, the third or fourth one?
This is our fourth one, actually.
It's the fourth one. Yeah, I've seen them all, and they get better and better each year. Although the one with Lisa Loeb was my favorite.
Well, she's back this year.
Are you serious?
Yeah, it's going to be awesome.
So excited. Okay, before we get to the juicy details of the concert, let's really get into some seriousness here. Colorectal Cancer Awareness Month happens every year in March, and it raises awareness about one of the most, significant cancers, most prevalent cancers in men and women. Would you say that? Can you just give us a little rundown about why this is such a serious topic?
Yeah, so it's the second most leading cause of cancer death, but it's also alarming. In recent years, we've been seeing a trend of early onset colorectal cancers being diagnosed. And the U.S. Preventative Task Force just decreased the age recommendation from screening. As everyone is probably aware by now, we've recently changed it from 50 to 45. Or you could say 45 is the new 50. So as a reminder that everyone should begin screening at age 45. And, particularly when the data was first analyzed, we were seeing an increase in colon cancers at age 49. So the thought was to start a screening colonoscopy at age 45 to detect polyps during the colonoscopy. And as gastrologists, we're able to remove the polyps with our instruments, with snares and biopsy forceps before they can turn into a cancer. And what's really alarming, and this is, from all of my colleagues and my experience since we changed the guidelines, we're seeing polyps that we would not even expect in a 45-year-old, like a centimeter-sized polyp in a 45-year-old that's just doing due diligence. They're very smart and aware of the guideline changes, or their primary care physician informed them of the guideline change. And they were like, yeah, let's do a colonoscopy at age 45, totally asymptomatic. And then we do their procedure, and I see, a 10 millimeter polyp or a 12 millimeter polyp, and remove it. And it's cool because we are actually in real time preventing colon cancer or colorectal cancer. And we are able to tell the patient right after the procedure that we were able to remove 1 or 2 or 3 polyps, and they're incredibly happy. And so this guideline change has been a huge success. That being said, we're also seeing cancers being diagnosed at even earlier ages than 45. So it's going to be really interesting over the next couple of years to see where this guideline shift ends up. Do we need to move it to an even earlier age? But currently we're at age 45. And I have a friend that I was working on a project with actually over the past couple of years. On the side, I work on TEDx here in Chicago, TEDx Wrigleyville. I'm actually the music director for that too. So I've been able to be part of a bunch of really exciting, cool music projects in addition to medical projects over the past couple of years. But even since the first year of Tune It Up, she was diagnosed with colon cancer earlier than age 50, and unfortunately just passed away. Because what's alarming, not only are younger people getting colorectal cancer, is that we're finding it in more advanced stages. And that was also part of the reason for the guideline change. And, this has really hit hard at home with me and my friends who have worked with her on this project. And, she was incredibly supportive of the Tune It Up project and helped share the concert. She was passionate about trying to get other people to get screened, other young people to get screened, starting age 45. And, this just happened very recently. So, yeah, as a gastroenterologist, we're passionate about every patient, but when it hits home hard like that, and I've also diagnosed my own patients with early onset colorectal cancer. But when it's a personal thing like that, it really, it's important for us to try to get as many people screened as possible.
Well, first of all, my sincere condolences for the loss of your friend. That is, it hits home, and it's unbelievable how the age has decreased, or how we're seeing more and more younger people diagnosed with this. And it affects all ethnicities and all, people of color, indigenous, everyone is affected by this. And I want to call attention, and we're going to have one of your colleagues on a podcast to talk about this in more detail. But in populations, minority populations, underserved, overlooked, marginalized, however we want to categorize this, they're diagnosed also at younger age, but at a stage that's later. So it's a later stage that they're diagnosed. So can you explain a little bit about that and why, what are we doing about that, and how can we get these people to see their doctors and get screened?
Yeah. So what's interesting is even during my fellowship, and I graduated in 2014 from my GI fellowship, there was already a recommendation in place for African Americans to start being screened, or at least to consider being screened at age 45. So that was actually the first population that we identified that there was early onset ARN. And then when people analyzed a lot more data, they realized that it wasn't just African Americans, it's really the entire population that was getting it. And we're particularly seeing this in the United States, and so much research is being done as to why. A lot of the leading theories are that it's probably related to our diet. People who eat a lot more processed foods, people who eat more red meat, which includes, and this is interesting because a lot of our patients aren't aware of this, both beef and pork. So pork is actually considered a red meat. People aren't eating enough fruits, vegetables, salads, fiber. There's some question of whether antibiotics may be playing a role in this, both that we're given and the antibiotics that are given to animals that we eat. And the fecal microbiome. And there's so many different areas that research is being conducted right now to try to determine what we can do to change our behavioral habits to try to prevent colorectal cancer from happening at early ages. But in general, most gastroenterologists are just encouraging our patients to be as healthy as possible. So trying to eat a piece of fruit or vegetable with every meal. That's a good way for our patients to remember to try to increase the amount of fruits and vegetables and salads in their diet. If we encourage our patients to eat more chicken, turkey, fish, a little less red meat, and we don't have to cut cold turkey. They don't have to, we have to be realistic here with our patients. But small incremental changes over time can improve healthy lifestyles. Trying to get people to quit smoking, that's another risk factor. And then obesity, and a lot of these new medications are going to help decrease the amounts of obesity in America. So we welcome them, and they're amazing and revolutionary. I'm going to do a whole another podcast just about weight loss management. But we think that the leading theories are that these different categories are contributing to early onset colorectal cancer in different ways. And what's interesting also, if you really analyze the data, while we see cancer rates increasing under the age of 50, over the age of 50, we're actually seeing an improvement. And there are a lot of theories about that. One is, as we have increased screening at 50 and over the past 20 years, we're able to remove polyps before they can turn into cancer. And so, it's really, really interesting that we've done such a great job at trying to remove polyps before they can turn into cancer at earlier ages and detecting cancers at earlier ages. But yet people under the age of 50 were seeing an increase. So hopefully by instituting these guideline changes, we can have the same impact on younger patient populations.
Yeah, and the American College of Gastroenterology also has age 45 now for their screening guidelines. Did that come first, or did the preventative task force, or was it together? I don't remember.
So it all came about around the same time. Yeah. The American Cancer Society was actually the organization that sounded the bells, the alarm bells for us to be looking at this. And very quickly, a lot of the GI societies met and analyzed the data. And it's been incredible that all these changes happened so rapidly.
Yeah. No, that's good news for patients. And I love how the guidelines have evolved to really meet the needs of patients and to hopefully prevent this potentially deadly cancer from happening. So what are your suggestions? You know, someone under 50 is listening to this, or even over 50, and they're like, oh my God, I'm afraid to go for colonoscopy. I've been hearing all these horror stories, like it's the prep and this and that. I know there's some other tests, screening tests that can be taken, but there's also pros and cons to both. Can you explain, you know, some of the more common screening tests that, you know, we hear on TV, on commercials? Oh, you can take this test, deliver it to your house. And, you know, how does that compare to a colonoscopy?
Yeah. So in general, gastrologists love performing colonoscopies. We love doing our procedures. And the advantage of a colonoscopy over the other screening tests that I'll get to in a second is that we can remove polyps before they can turn into a cancer. So if one of the alternative screening tests like Cologuard or FIT turns positive, which is they're great screening tests, we test their stool, or patients will test their stool. Cologuard specifically, they'll send it off in a UPS box that gets sent to a central lab. That's a really incredible lab. It's really amazing the work that Exact Sciences has been doing with Cologuard. But basically, they look for DNA markers and they look for polyps and colorectal cancer itself. And if it turns positive, then the patient then needs to get a colonoscopy. But the advantage of Cologuard is that it's good for 3 years. Now, FIT testing is an alternative, and it's also a stool-based test, but it needs to be done every year. So you have to make sure that the patient comes back every year to get that performed. So they all have their advantages and disadvantages. The one thing that I will emphasize is that the best test for the patient is the one that gets done. So it's important for all of us, primary care doctors and gastroenterologists, to have an honest conversation with the patient when they come in and to try to determine what their goals are. You know, when patients are hesitant to get colonoscopies, frequently it is the prep that they're afraid of. And so if we just take the time to explain how to prep and give like little pearls of wisdom to help them get through it, you know, most patients are very open to getting a colonoscopy after you explain that. But, you know, if people are really busy, they don't want to take off a day of work, totally understand. They're taking care, you know, the excuses I hear frequently is that they're taking care of a loved one. And that's why. And these tend to be older patients than people 45. But, you know, if they have a spouse that's sick or a parent that's sick, you know, they're more focused on their loved one than they are on getting screened themselves. And so that's a great time to use Cologuard. Another great opportunity to use Cologuard is, you know, you have a patient that was adamant that they didn't want a colonoscopy. Unfortunately, they didn't have a good enough prep for us to be able to see the entire colon. And they're like, Doc, I don't want to do this again. I really didn't like that experience. Is there anything else I can do? That's a great patient to use Cologuard on because it'll give them 3 years. They don't have to drink the prep again. Now, separately from that issue, we have a bunch of new preps out there. And this is a very exciting time in gastroenterology. So if I could highlight a couple of the new preps that are super popular. So we have all kinds of low volume preps. Some of the popular ones are movie prep or soup prep, and works great. It's a lot less to drink, a lot less volume of fluid to drink, and patients tolerate it a lot better than the traditional Go Lightly prep. In addition to that, recently, I think it was last August, Soufflave, which is the first FDA approved flavored prep. It's lemon lime flavored, and that got approved. And it's very similar to soup prep, except that it has flavor. Unfortunately, occasionally it costs a little bit. Sometimes there are discounted cards that they can use at the pharmacy to get it approved. But if patients are really afraid of the taste of the prep, the saltiness, that's a great way to help them. And then there's Sutab, which are tablets that patients can take. Now they have to drink a lot of water with it, so we always caution patients about that. But we have so many awesome options out there that the prep really shouldn't be interfere with them wanting to get a colonoscopy anymore.
Yeah, no, I agree with you. And last year we did a special episode with Dr. Carol Burke, and we talked specifically about preps. There's also some companies like Happy Colon that have prep foods. It was developed by a doctor. I don't know much about it. We'll have him on too, because we've been meaning to have him on to talk about that and how that can assist with the prep. And also dietitians have given recommendations on how to sip maybe broth or clear liquids that kind of can take the edge off of, you know, feeling like you have to drink this icky stuff all the time.
Yeah, I have some personal pearls that I use with my patients that I did myself when I had my colonoscopy.
And what did you do?
So, what?
What did you do?
Okay, so one of the things is, so separately from this, there's also Gatorade Miralax Prep that's been used for years. And, you know, a lot of gastroenterologists are okay using that too. So this is really an individual conversation that each patient needs to have with their provider. So we can help guide patients to what is the best possible prep for them. But some pearls that help a lot of my patients are that, you know, so it's important to have a clear liquid diet all day, the day before your colonoscopy. Now, there's some people that will just buy broth that's canned. That's fine, but it doesn't taste the best frequently. And so if people really make homemade chicken broth, that's even better because, you know, it doesn't seem as bad of an experience all day leading up to it. I think that's part of the stress that people have, is that a lot of the foods that people eat are so bland or salty. They don't or sweet that they don't particularly enjoy the experience. So if you make your own chicken broth, just make sure there's no carrots, celery, noodles, chicken, like just the broth.
All the good stuff.
Yeah, yeah. So, no, I mean, and there's some restaurants that will sell chicken broth by itself.
And there's bone broth, right? Is bone broth count? It's clear.
Yeah,
it's clear.
You just have to be careful not to have too much fat or protein in it, because we don't want that to cause stool from forming. But as long as you skim the broth that you make yourself, and it's literally just the broth, nothing added to it, that's fine. Another great thing that patients can do is to pour themselves a glass of like white, not red, but white grape juice or apple juice. And if you have a couple sips of that in between each half glass or glass of the prep that you've chosen to take, that will also help patients, because it's goal oriented. It gives them something to look forward to after each half glass or glass. And it takes out the saltiness out of your mouth. So it's something sweet to look forward to. I like to think of it as your dinner that night. So you're not having anything else other than prep. That's like you're the end of the day. So it's like just a little bit to look forward to. It makes it more goal oriented. And the other thing that we should always emphasize is that the prep should be split prep. And so you should talk to your gastroenterologist about exactly how they want you to do it, whether it needs to be a tie-up space between the first half of the prep and the second half of the prep. And that's really important. We have a lot of data that shows that we get high quality preps when patients have split dosing. The other thing to keep in mind is you don't want to slam the second amount of prep at the last minute, because the other thing that we frequently see during our colonoscopies is that patients waited to the absolute last time that they could drink anything to finish their prep, and it hasn't had enough time, especially if you have an early morning procedure. Sometimes it hasn't had enough time to do its work and to get out of the colon. As if you think about it, when we do procedures, we tell patients not to drink at least 2 hours anything before their procedure.
Right.
And that's part of the ESA guidelines, what anesthesiologists use to prevent patients from aspirating. The logic behind that guideline is it takes liquids 2 hours to exit out of the stomach and to go from the stomach into the small bowel. So if you think about it, if it takes liquid 2 hours to exit out of the stomach, drink prep works the same way. So you need, that's not counting the time it takes to go through the small bowel or the colon itself. And so we need to give the prep enough time to work. That being said, you also don't want it to get too early, because, you know, in some patients it causes a little bit of dehydration if they drink it too early. So there's a happy medium. So talk to your gastrologist or your PA or nurse practitioner or primary care doctor.
Yeah, and that's a great point, patients. There's no one size fits all. We want you to know about these options, to have a good conversation with your doctor. Tell them your fears. Tell them what you're afraid of and you don't think you're going to like. And they can work with you. There's a lot of different ways to do the prep. And the prep is so important because why, Dr. Levy? Why is the prep so important?
Because if you don't drink the prep properly, we can't see in your colon. And first of all, if we have to clean up a lot of the prep, it's fine. I look at my job because I'm a colon cleaner. That's part of my job. I vacuum out residual prep and stool all
like
the
a
time.
Shop. Do you guys use a shop vac or what do you use?
It's like one. There's a big channel on our scope and we literally suction out any residual prep. But the thing to keep in mind is if there's residual prep there, we will attempt our best to clean it up, but it takes longer, extends the time for your procedure. And so we don't want that. We want to be able to just focus on removing the polyps. We do just as good a job on anyone that has residual prep in their colon as if they don't. But we're a lot happier when we don't have to spend extra time, cleaning out every single section of the colon. So it's important to follow the instructions properly. The other thing is a lot of patients will drink, like 75 or 80% of the colon. And sometimes it's okay. But we never encourage them to do that. It's important to drink the entire amount, whatever they gave you, drink the entire amount of prep because we want to give it the maximum chance of working.
Oh, you want us to drink
it's not that
everything.
We're going to cancel a procedure if they drink 80%, but we tell patients there's a chance that their prep might not be good enough to see everything, and they may need to come back sooner than 10 years for their next colonoscopy. And so we really want to give patients the best chance to wait a whole 10 years. And also it's dependent on what we find. If we find large polyps, they'll have to come back sooner. If they have multiple polyps, they'll have to come back sooner potentially. So we do everything based on, the recommendations are based on both the number, the size of the polyps, and the prep quality.
So do you tell your patients, chug-a-lug, patients, make sure you drink it all. It's important.
Yeah.
And we're just kind of having fun here. We're not belittling this procedure. It's a really important procedure, but we want to make it palatable and know that you're going to be okay. Just work with your doctor and follow the instructions, which is probably 99% of the fear is maybe not understanding the directions.
And I think having a understanding of what they're about to do helps a lot, and it minimizes the fear. The patients that have had loved ones do the procedure, they're definitely less apprehensive about it. So that's a huge help. Some practices will have a video to help patients prepare. That's always super helpful. We have handouts from our different GI societies that we can also provide to patients. There's so many different ways. But I think the most important thing is for the actual provider to have a conversation, individualize their approach based on what they're afraid of, and talk with them about it. And we can get patients through it. The other thing to always keep in mind, we're talking about patients just getting their screening colonoscopy, but what about all of our ulcerative colitis and Crohn's disease patients that need to have frequent colonoscopies, and they're able to tolerate it? So, yes, we all understand the fear. It's not the most fun thing in the world, but we can get you through it. And it's totally worth it, because if we can save a life or prevent you from getting colon cancer, it's totally worth, the little bit of extra work you have to put in one day beforehand.
Well, and I mean, I've had 2, and I think it's like the best sleep ever. When you feel like when you wake up, you feel relieved that you've gone through this procedure and you're okay. But my God, I feel like I had the best sleep ever. I don't know what they do, but
a lot of patients say that the propofol that we use for sedation.
Oh, is that
yeah. Well, there are different ways to say. Sometimes we use Versed and fentanyl, and sometimes we use propofol. Propofol is what's given by an anesthesiologist.
Yeah,
and a lot of patients wake up saying it's the best sleep they've had in months.
Oh,
even though they've only been asleep for like 30 minutes.
Yeah, it's amazing. And my first colonoscopy, I actually braved it out for a little bit, and I wanted to see what they saw on the screen. And I could tolerate that for just so much, but then I guess they use gas to inflate the colon. Mm-hmm. So that was a little bit uncomfortable. And then I'm like, okay, but I could actually see, and I definitely did a great job on my prep.
That's awesome. See? Well, you should, because
it was pretty in pink, I have to say. It was great. It was great. But in all seriousness, this has been so great. And now I want to really give a great highlight to this awesome concert. You've set the stage for why it's so important that you're doing this concert. Tell us about the concert and what happens and who's going to appear and how it all works. March 28th.
Yeah. It's 8 o'clock Eastern, 7 Central, 5 Pacific. It's a free virtual concert online. It's on the American College of Gastrology's website at gi.org/concert.
Yeah, we'll put that up on the slide for those of you who are watching video, and we'll put it in the description as well. So tell us the juicy bits about who's going to sing this year, who's going to perform.
Okay. So I'm super excited to announce that Colby Calais is...
Stop it.
Yeah.
Really?
Yep. A Great Big World. And this is that Lisa Lowe, Rufus Wainwright.
Oh my God.
Ali Venable Band. We have so many different performers this year.
This is so great.
The concert has really taken off over the past couple of years. This is our 4th time doing it. It started during the pandemic as a way to do an outreach program for the public. There were a lot of musicians that were at home, and I thought of the idea of trying to team up musicians, and it's all genres of music, a lot of rock, jazz, classical, country, blues, hip hop, Broadway, and to pair them up with gastrologists and public health experts to teach the public about colorectal cancer screening. And also, really, when we first started this, we wanted to emphasize, the early colon cancer screening age of 45. And that's been a major change. We've been very fortunate that the musicians have generously contributed amazing videos the past couple of years for our concert. Last year, we had John Baptiste, who was on Stephen Colbert show. We've had Ben Folds.
Violet. KF is my favorite. KF Jacques going to come back this time?
We're working on it right now, actually. Yep.
Well, tell him.
He actually is releasing a new opera on Thursday.
Oh my God. So he's busy.
Yeah, so we're trying to figure out what to release.
He's amazing. I love him. All of them are amazing. I can't wait for this again. So the year before we had a gastroenterologist band. Do we have that this year?
Yeah, the Beacons have played. Yep. We actually the mid-year conference that we recently had in Vegas. It's the Board of Governors meeting, and there's an academic conference that happens at the same time. They invited me to play the cello with them this year. So we recorded a song, especially for Tune It Up. So we'll get to feature that.
So the Beacons and special guest Dr. Ben Levy on the cello.
Yeah.
This is going to be fantastic. I cannot wait.
But everyone else is a professional musician, and it's going to be a really special concert. Again, people can watch it. It's free. It's a little over an hour, and basically
goes by so fast. Trust me. Like every year, I'm like, oh my God, that's it.
We just filmed all the introductions yesterday. Actually,
so good.
We have a really nice piano store in Chicago named Pianoforte, and they have generously donated the past 3 years their space for us to record the video intros. But yeah, we cram a lot of music into an hour, and I have to thank the American College of Gastrology, their communications team and the IT team in particular do such a fantastic job at the concert.
I think it's such a brilliant way to raise awareness, and everyone loves music. And I think there's such a great correlation between the brain of a doctor and a musician. I think there's so much synergy, and you get to see this beautiful event, because you had the thought and the thinking to bring it all together, and for a great cause. And I'm so happy just to be a part of what little piece we play in raising awareness. But I encourage our listeners to check out the concert on March 28th. Looking forward to it so much. Thank you so much, Dr. Levy. This is fantastic.
Thank you for having me.
Great to have you again.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.